session to evaluate ocular surface damage and tear function test in patients with hypothyroidism, and control. Thank you, sir. Good afternoon, everyone. Next. We all know what is dry eye syndrome. It need no introduction. Just for the sake of people, I'm saying it's an ocular discomfort leading to blurring of vision, burning, itchiness, redness, grittiness in the eye. We all are aware of dry eyes present in hyperthyroid cases. Now there are studies which also say that dry eyes are present in hypothyroid. So in this study, I aim to evaluate the presence of dry eyes in both hypothyroidism, and control. So aims and objectives to evaluate and compare tear function tests, that is Schirmer's test, tear breakup time, OSDI, and ocular surface characteristics in patients with recently diagnosed cases of hypothyroidism, and control. It was a clinic-based prospective study conducted in Mahatma Gandhi Medical College Hospital, Jaipur for a period of 15 months. All my patients were recently diagnosed within 2 to 3 months of the active diagnosis of thyroid. They were chosen and they were all aged between 20 and 65 years. They were excluded if they had any other ocular surface disorder, glaucoma, tropical or systemic medical usage prior to examination, contact lens and all written consent was taken. Now evaluation of tear function test, there was OSDI, ocular surface disease index. I need not go into detail of these things, it's all general. So Schirmer's test, tear breakup time, and when to compare the ocular surface, I did the impression cytology. It was done from temporal interpalpable conjunctiva, and the grading was done according to Nelson's, and the staining was done by periodic acid shifts and hematoxylin. The Nelson's grading, there are 4 grades, and they are grade basis on the nucleocytoplasmic ratio and presence of goblet cells. The result, the statistic analysis is after the 70% of the newly diagnosed cases were females and 60% were hyperthyroid and 71 hypothyroid. The average age was 47 and 46. The important thing to note here, the BCVA proptosis and interpalpebral distance did not show any significant distance between the cases and control since they were recently diagnosed cases. So the OSDI scores in control, if we come to it, was 29. In hyperthyroid it was 42, and in hypothyroid it was 41. The Schirmer's test, it was 17.6 in controls, 12.9 in hyperthyroid, 13.3 in hypothyroid. The tear breakup time was 11.15 in control, hyperthyroid 7.18, and note please, the hypothyroid had more damage in tear film. It was 6.38 seconds. The impression cytology showed significant squamous metaplasia in cases of hyperthyroid and hypothyroid. So the mean Schirmer test score was decreased, tear breakup was reduced, and OSDI was increased, definitely suggesting dry eye was present. Grade 2 to 3 squamous metaplasia was also seen. Now proptosis and palpebral fissure height absolutely showed no difference between cases and control. Yes, dry eye was present. So definitely there was a question that there has to be a something alternative mechanism other than proptosis and increase in palpebral fissure height. So I studied, reviewed, and all I came to the ideology. There are 2 charts I want to show. The basic thing in hyperthyroid cases, there is the TSH receptors are located on lacrimal glands and orbital muscles. So with these antibodies, they attack the lacrimal glands, leading to decrease in tear function. The main culprit in every diagnosis in hypothyroid and hypothyroid is hyperosmolarity of tear film. Once tear film is hyperosmolar, there it stimulates a cascade of inflammatory cytokines like interleukins and MEP, and there is ocular surface inflammation leading to squamous metaplasia and loss of goblet cells. So in the hypothyroid, we can see it clearly. There are 2 mechanisms. One, initially in the cities is due to antibody against lacrimal gland, but once it has increased, there is hypertrophy of orbital muscles, there is proptosis, eyelid retraction, so there is tear film evaporation. So in cases of hypothyroid, we have dry eyes because of 2 reasons. In cases of hypothyroid, we have basically thyroid hormone is responsible for normal oxidative metabolism and free radical eradication. Or if it is deficiency, obviously there is oxidative stress and accumulation of free radical, leading to damage in lacrimal glands and ocular surface. Again, the same thing, hyperosmolarity comes into the scene. Obviously the stimulatory inflammatory cytokines and everything comes and leading to squamous metaplasia. So you see the thing, a dry eye, the end result is common. Both hyperthyroid and hypothyroid are dry eye, but the way to achieve it is different. So we conclude that association is more in thyroid patients as compared to control. The DRA and tear function test correlates. Dry eye in patients of thyroid function is attributed to ocular surface inflammation due to hyperosmolarity rather than tear film evaporation. So my recommendation is to routinely investigate all women of 30 to 50 years. We need to have proactive ocular surface dry eye evaluation, tear breakup time. We should refer them to surgeon, physician, endocrinologist, and once dry eye is definite, they require a proper treatment. Thank you.
None of the authors have any financial disclosures to make pertaining to this study. Next. Coronavirus have off lately suggested us and shown us the ability for it to change the disease. Recently, a publication by Finlay et al. Also suggested that the non-communicable diseases like diabetes, cancer, and obesity are now becoming communicable because of the changes in microbiome affected by bacteria and virus. Also, the medical world has now started emphasizing on the role of microbiome and has also proven that its role of microbiome leading to multiple inflammatory disorders and cancers of the systemically. Our group and multiple other groups have shown in the past that there is a role of inflammation which drives eye rubbing and in turn which leads to keratoconus. So we now know that inflammation leads to eye rubbing, which leads to low levels of LOX and collagen, which leads to keratoconus. But the question is, where is this inflammation coming from? Like other systemic conditions, is the ocular surface inflammation also driven by this unknown bacteria or the microbiome? We wanted to study that whether the microbiome is leading to this ocular surface changes or it's also leading to keratoconus. But the challenge here was, how do we study the microbiome of the eye? Because 30% of this patient bacteria cannot be cultured or stained. So how do we overcome this challenge? We decided to do the microgenomic sequencing of this bacteria from the ocular surface and study the disease pathway. This is how the study was designed. It included 3 arms: the genomic analysis, the ocular surface immune cell analysis, and the inflammation arm from the tears. It was a prospective interventional study with prior ethics committee approval and patient consent. We had a strict inclusion and exclusion criteria. Patients with prior contact lens use, history of eye rubbing, history of any prior eye surgery or treatment were excluded from this study. We included 35 healthy eyes and 54 keratoconic eyes spread over different grades of keratoconus. All the patients underwent detailed clinical and topographical evaluation before getting recruited in the study. What we did was we collected the ocular surface from the lower fornix and the upper fornix. We extracted the DNA from this ocular swab and performed a 16 RS genomic sequencing. And the unknown database which we found from this was compared to the known database to classify the new disease pathology. This is how the tree of bacteria looks like, and this is how they are classified. What we found here is all these bacteria were found in the patients of ocular surface of this patients included. Interestingly, the tenerocutis and the thermocutis were found to be higher in keratoconic eyes and which were not present in the control arm. Also, the proteobacteria, which is the bad bacteria for the keratoconus, and the acinobacteria and the firmicutes, which are the protective bacteria in keratoconus, were deregulated, suggesting that yes, there is a role of bacteria which leads to disease called keratoconus. And also interestingly, we found that the load of bacteria, the abundance, and also the various unclassified microbiome genetic bacteria were increasing with the increasing grades of keratoconus. Next question was, how do these bacteria influence the immune trafficking cells on the ocular surface? We devised a novel technique where we collected the ocular surface wash for these patients and stored in these tubes. They were then transported to the lab, and flow cytometry was done to study the specific cell types and to quantify the same. What we found was that the leukocytes, the neutrophils, and the neutrophils T lymphocyte ratio, which is the protective mechanism, was lower in the keratoconic group compared to that of controls. Also, the activated neutrophils, the T lymph cells, and the macrophages, which are the harmful cells, were higher in the keratoconic group compared to that of controls, suggesting that yes, there is the altered immune cells on the surface can drive the disease. Is there an interlink between the bacteria and inflammatory cells? We did tear analysis, and what we found and matched with the published literature was IL-8, CD121, and the MPO levels, which is affected in keratoconus, was significantly correlated with actinobacteria. Proteobacteria positively correlated with the inflammatory markers IL-17A and IL-12, which is known to affect the LOX and the collagen levels. The lower the LOX and the collagen levels, which in turn leads to the keratoconus disease. Perforins, which has the cytolytic effect, which kills the cells, was higher in the keratoconic group, positively correlated with the bacteriocytes. And if we do a surgery on this kind of patients, they post-operatively they can land up into haze. Thus, altered microbiome can lead to altered ocular surface immune profile, which in turn can lead to increased inflammation on the surface, which drives the disease. But how does this disease impact the disease clinically? It can lead to disease progression where we have not operated the patients. If we operate with cross-linking, post-operative complications like infiltrate and haze, and also failure of treatment of cross-linking can happen. At this point of time, inflammation can be stopped with medications like cyclosporin, lifitegrast, and 3-halose. But how do we stop this unknown, unclassified bacteria? We are currently working with pharma companies to develop these newer antibiotics, which are the epigenetic modulators to target this cluster of unknown bacteria. And the Ocular topical probiotics would be the wave ahead to control this microbiome. Thus, this is the first ever reported study for the role of microbiome of unclassified bacteria in keratoconus. Altered microbiome affects the keratoconus disease, which possibly drives the eye rubbing and inflammation on surface, and we need to modulate this inflammation and eye rubbing by blocking the bacteria. Thank you.
Distinguishing ocular surface squamous neoplasia from pterygium by various imaging modalities. Although all these 4 lesions came out to be positive for OSSN on histopathological examination, but clinically it is not always feasible to distinguish OSSN from pterygium. The following are the differential diagnosis for pterygium. This is important because OSSN has a protocol-based management which includes margin clearance, cryotherapy, and proper follow-up, which if not done will increase morbidity. In this particularly, pterygium is important because our country has low latitude and high UV exposure. So we ask the question, can we reliably distinguish ocular surface squamous neoplasia from pterygium by multiple imaging modalities? We did a prospective cross-sectional study. We defined the gold standard for diagnosis of OSSN as typical histopathological features and or showing response to topical chemotherapy. Then we compared the presence or absence of certain known features on the imaging modalities. The known features of OSSN on ASOCT are hyperreflective epithelium and abrupt change from the affected tissue to the non-affected tissue. The known features of OSSN on confocal microscopy are variation in cell size and starry sky appearance. The known features of OSSN on ultrasound biomicroscopy are fusiform thickening and hyperechogenicity with internal hypoechogenicity. The slit lamp examination is assessed for the presence or absence of limbal location, corneal extension, keratin, or pigmentation. The red-free filter examination is done to assess for feeder vessels, rose Bengal staining, or presence of intrinsic vascularity. We took 18 cases each of pterygium and OSSN. 2 examiner masked to the final diagnosis, and each other's findings evaluated the images of the lesions. The lesions were studied under the following headings: clinical examination, red-free slit lamp examination, ultrasound biomicroscopy, anterior segment optical coherence tomography, and in vivo confocal microscopy. Each characteristic under a category was given a score of 1 if it was present and 0 if it was absent. The score for all the characteristics in each category was average. The Bland-Altman analysis was done, which showed a good correlation between the scores of the 2 observers. So we did the scoring on slit lamp photography. On clinical slit lamp photography, both OSSN and pterygium showed similar scoring, but on red-free filter examination, OSSN showed higher scores than pterygium, especially on rose Bengal staining and feeder vascularity, which was statistically significant. On confocal microscopy, both OSSN and pterygium showed similar scoring. And on anterior segment optical coherence tomography, pterygium showed better scoring than OSSN, but it was not statistically significant. Again, on ultrasound biomicroscopy, OSSN showed a better scoring than pterygium, but it was not statistically significant. We observed that only on red-free slit lamp biomicroscopy there was a statistically significant difference between OSSN and pterygium. So we concluded that meticulous slit lamp biomicroscopy, red-free filter examination and rose Bengal staining is more effective in differentiating OSSN from pterygium than confocal microscopy, anterior segment optical coherence tomography or ultrasound biomicroscopy. Here are my references. Thank you.
Did you have a
Good afternoon, everyone. So the study is on the outcomes of ruthenium-106 plaque brachytherapy in ocular surface squamous neoplasia with scleral invasion. OSSN is more commonly known as ocular surface squamous neoplasia. No financial disclosure. So OSS can extend horizontally into the corneal epithelium and stroma, and a little more uncommonly vertically into the sclera. Any suboptimal management in the early stage of OSSN, either due to incorrect histopathological diagnosis regarding base and margin involvement or due to inadequate treatment despite the correct histopathological diagnosis, can lead to progression of the lesion and multiple recurrences. Any scleral invasion can progress to involve intraocularly or into the orbital tissue that can lead to, unfortunately, enucleation and exenteration. So the purpose of this study is to investigate the safety and efficacy of ruthenium-106 plaque brachytherapy in the management of OSSN with scleral invasion. This is a retrospective interventional case series from a tertiary eye care center managed over a period of 5 years of patients presenting with primary or recurrent OSSN. So almost all patients underwent conjunctival wide excisional biopsy with 4 mm wide margin, followed by alcohol keratoepithelectomy for corneal involvement, followed by lamella sclerectomy for the scleral base, and cryotherapy to the resected conjunctival edges. This sample was then submitted to the histopathology for assessment of the scleral base and the conjunctival margin, and all those patients who had positive scleral base underwent further ruthenium-106 plaque brachytherapy at a dose of 5000 centigrade. Results: the mean age of this of the patients in this series was 49, and majority were males, and only 2 patients were positive for HIV. The visual acuity was greater than 20/40 in 67% of the patients. About 95% of the patient had tumor location in the limbal area, 95% had in the nasal or temporal bulbar area, and 88% were nodular in morphology. The preoperative mean tumor basal diameter was 9.3 mm. The mean tumor thickness was 3.1 mm. 93% of the patient had corneal involvement, and the same number had about clinical scleral fixity. So on histopathology, all the 42 patients showed scleral base positivity, obviously because this was our study group, and only one of the patients of these 42 had margin positivity. So our results with the ruthenium-106 plaque brachytherapy was excellent, with 100% tumor regression, as you can see in this patients and the following photographs. The surgery-related complication was 0, and radiation-related complication were 2, and that was just recurrent corneal epithelium defect, which was managed conservatively. Tumor recurrence was noted only in 2 patients, but this was at a site remote from the original tumor site, which was again treated with excisional biopsy, and since again scleral base was positive, they were retreated with plaque radiation. The mean duration follow-up was 37 months, and during this time frame, there was no patients underwent enucleation, there was no exenteration, lymph node metastasis was not seen, and no patient had systemic metastasis. Visual acuity of greater than 20/40 was maintained in 24% patients, and only 1 patient had reduction in visual acuity, and this was due to recurrent corneal epithelial erosion. So what does our result add to the existing literature? Most of the earliest reports of use of plaque brachytherapy in OSSN was using strontium-90, and the ones that reported use of ruthenium-106 plaque brachytherapy in OSSN was in the form of case reports of 1 or 2 patients, and there was no clear indication as to when exactly the plaque brachytherapy was to be used. In this case series by Shields et al. From Wilza Institute, they used iodine 125 plaque radiation, and this case series was only of 15 patients, and because of the gamma radiation of iodine plaque brachytherapy, most patients ended up with a multitude of complications including cataract, iris telangiectasia, corneal epithelial defect, and corneal edema and glaucoma. Further, 4 patients underwent enucleation or exenteration. In comparison, our results have much better. In our case series, we used ruthenium 106 plaque brachytherapy. This was the first series from Asia, the largest series worldwide, and the longest with longest follow-up duration time. There were minimal complications, and our paper showed that this plaque brachytherapy was to be used only as an adjuvant therapy and not as primary brachytherapy, and also that histopathology is an important diagnostic tool. So in conclusion, histopathology guided use of ruthenium plaque brachytherapy is a safe and an effective adjuvant therapy in the management of scleral invasion of OSSN. Our study recommends that the primary management for all patients of OSSN be wide excision biopsy with lamella sclerectomy. An expert opinion is to be sought from an ocular pathologist. If the scleral base is negative for tumor cells, nothing to be done but to observe the patient periodically. But if the scleral base is positive for tumor cells, these patients definitely require an adjuvant treatment in the form of surface plaque application. Thank you.
In your series, the only complication was
Meibomian glands using autorefractometer, a very simple and effective tool. I have no financial interest to disclose in this paper. So Meibomian gland dysfunction is a major cause of dry eye syndrome. Morphological changes include tortuosity, shortening, dropouts, dilatation and distortion. These can be precisely measured using meibography, which is a very expensive tool, and it would be available only in major institutes. We describe here a very simple technique which day-to-day practice every practicing ophthalmologist can apply to view the meibomian gland morphology using a simple autorefractometer. So the aim of the study is to study the morphological pattern of the meibomian glands using autorefractometer. So this is a prospective non-interventional study. Study period was between January 2019 to March. Sample size 60 eyes of 30 patients diagnosed with meibomian gland dysfunction, which includes symptoms, meibomian gland blockage, expressibility, lid margin telangiectasia were studied. This was the age group, majority between 50 to 60 and up to 80 age group was included in the study. Most of the patients presented with burning, foreign body sensation, and itching was seen in some amount of patients, and reflex tearing in 5.8% of the patients. Ocular surface disease index score was assessed on a scale of 0 to 100. Higher the score, greater the disability. The range was between 25 to 69.4 and the mean was 47.2. So it was mild in 25 eyes, moderate in 15 eyes, and 20 eyes had very severe dysfunction. Lid margin changes include meibomian gland block of various degrees, which I will be showing later. Almost all the patients had meibomian gland block. Frothing was seen in 24 eyes. Vascularization, keratinization and rounding up of posterior lid margin were seen. Tear film height was studied. It was 0.25 in 75% of the patient and 0.5 in 30% of the patients. Tear film breakup time was less than 5 mm in 25 eyes and 6 to 10 mm in 5 eyes. Meibum expressibility scores was assessed from 5 glands. If all the glands were expressible, the score was 0, and score 1 means 3 to 4 glands are expressible, score 2 1 to 2 glands, and if there are no glands are expressible, the score is considered 3. So majority had a score of 2, that is 50% of the patients. The secretion, quality of the meibum secretion was also assessed. It was assessed in each of the 8 glands of the central third of the lid on a scale of 0 to 3 for each gland. Score 0, when you express, the content was a clear meibum, Score 1 was a cloudy meibum. Score 2 was cloudy with debris, granular debris, and score 3 was thick toothpaste-like excrescences. So in this, 32 eyes had score 1, 26 had score 2, and 2 had score 3. Meibomian gland dropout score was also studied. It can be partial or complete. It was obtained from upper lids using a subjective 4-grade scoring system. Grade 0, all the meibomian glands were present. Grade 1, the gland dropout area was less than 1/3 of the total meibomian glands. Grade 2 was 1/3 to 2/3, and grade 4 was total gland dropout. So this is the meibomian gland dropout score, which was grade 2 in 37 eyes, grade 1 in 18, grade 3 in 3 eyes, and grade 4 in 2 eyes. So normal meibomian gland architecture, as you do autorefractometer, you can just invert the lid, and these infrared rays clearly capture the meibomian gland architecture. Here you can see the nice normal course of the meibomian glands. And towards the left, you can see the dilated glands, and towards the right, where they are very dilated, tortuous, filled with all these sebum. And clinical picture, you can see the lid margin changes, telangiectasia, then plugging of lid margins, plugging of secretions, etc. Here partial dropout can be seen in the left side of the picture, where very few glands, the two very irregular outline can be seen. And on the towards the right, there is a total dropout. No meibomian gland architecture can be visualized in this. So the clinical picture is compared below. It's very poor outcome. So in these patients, you have to not many substitutes are available. So with the help of the autorefractometer, you can come to a conclusion like whether it is salvage, can be salvaged by medical therapy, or it will require advanced therapy like IPL or LipiFlow. So to conclude, the autorefractometer is a simple, inexpensive tool that can be effectively used in assessing the meibomian gland morphology in day-to-day practice. This would help us in precisely diagnosing the etiology, diagnosing the level of meibomian gland dysfunction, and thereby indicating appropriate therapy. Thank you for your patient listening.
Okay, thank you very much.
Thank you, sir.
To all of you, my paper is on supratenonal excision of pterygium, a novel technique of pterygium surgery. I have no financial interest in this topic. So pterygium is a common ocular surface disorder that is characterized by hypertrophy of the subconjunctival connective tissue and overlying epithelium. It causes cosmetic complaints, ocular motility restriction, and visual disturbances, and have propensity to grow and recurs frequently after surgery. To prevent the recurrence, adjuvants are used to reduce the proliferative activity of stromal fibroblast during the postoperative recovery phase, like application of mitomycin C or fluorouracil or intralesional steroid injection, or we have to cover the wound with conjunctival flap, amniotic membrane graft, or conjunctival autograft to allow rapid epithelial wound healing. Since large open wound after pterygium excision inevitably results in severe pain, which induces exaggerated wound hypertrophy leading to pterygium recurrence. Hence, we have devised a novel technique of minimal wound recreation with rapid epithelial healing by excision of supratenonous part of pterygium with limbal stem cell graft, popularly known as a STEP. The purpose of our study is to evaluate the outcome of pterygium surgery with this technique. This is a prospective study of 36 eyes of 36 patients who were operated between May 16 to March 18 and followed up till March 19. Patients who are having primary pterygium who are followed up till 12 months were included in the study, while recurrent pterygium were excluded. Written informed consent was obtained from all the subjects with explained procedure and involved risk and complications. All surgeries were done under topical anesthesia with 0.5% proparacaine. 0.2% bromidine eye drops were instilled 2 to 3 times at interval of 5 to 10 minutes before surgery to blanch the conjunctival vessels and minimize intraoperative bleeding. As the surgical technique, first we have to inject xylocaine with retinine subconjunctivally, and then we have to dissect that pterygium at the limbus, sparing the tenons behind. And then pterygium tissue is removed from the cornea. Then we have to separate subconjunctival fibrovascular tissue, leaving the tenons attached behind with the sclera. Now we have take triangular flap of limbal tissue from the superior part of the limbus and it is placed over the tenons, keeping the apex towards the canthus, and over that bandage contact lens is applied. In post-operative period, prednisolone acetate eye drop is given in weekly tapping doses for 4 weeks, moxifloxacin 4 times daily for 1 week, and carboxymethyl cellulose 4 times daily for 4 weeks. Bandage contact lens were removed after 1 week. Patients were followed up regularly till 12 months. At each visit, status of surgical site was assessed in terms of pterygium recurrence, cosmesis, and patient comfort. Results. Total 36 eyes of 36 patients were evaluated, out of which 61% were male and 39% were female. Means age of the patient ranged between 70 to 62 years with a mean of 38.44 years. Surgical time ranges between 8 to 18 minutes with a mean of 13.3 minutes. Cosmesis was achieved in 1 to 2 weeks in all the cases, which is defined as complete resolution of inflammation and healing of the wound. All subjects were comfortable by 1 to 2 weeks of surgery, which is defined as absence of pain and foreign body sensation. Recurrence occurred in 2 cases, which is defined as fibrovascular tissue over the corneoscleral limbus onto the clear cornea. First case occurred after 6 months and another case after 3 months of the procedure. So, pterygium is a common ocular surface disorder whose treatment is ultimately be surgical. In published literature, there is no consensus about the surgical technique and use of adjuvant therapies. Various literature reviews shows that conjunctival limbal autograft had least recurrence rate of 0 to 15%. Our technique of a step is having recurrence rate of 5.56%, which is either comparable or even better than explained techniques. We have seen our recurrence at 3 months and 6 months in 2 of our cases. Literature suggests that 91.6% of the recurrence appeared by 360 days after surgery, irrespective of the technique and type of adjuvant chemotherapy administered. Hence, 12-month follow-up period is optimal for identifying recurrence of pterygium. Also, we found faster healing of surgical site, achievement of early cosmesis, and patient comfort within 1 to 2 weeks, which is better than other techniques. So, average surgical time in described previous techniques were 35 to 50 minutes, but our step is having mean surgical time of 13.3 minutes. Our method entails shorter surgical time as conjunctival graft procurement and suture was not required. Other advantage of this technique is it is free from graft and suture related complications. Our technique is based on the fact that a large open wound after pterygium excision results in severe pain, which induces exaggerated wound hypertrophy, leading to pterygium recurrence. In addition, delayed wound healing may induce alternative and prolonged stromal overgrowth, most likely due to a lack of contact inhibition with the overlying epithelial cells. Our technique causes minimal wound creation and sclera is always covered with an overlying layer of tenon capsule. Hence, the inflammatory cascade is limited, resulting in wound repair with minimal scarring. Wound site is replenished with limbal stem cell graft, resulting in rapid epithelialization of the wound. Bandage contact lens stabilizes the limbal stem cell graft, which facilitates healing and provide pain relief. All these factors helps in preventing the recurrence. Limitation is a small sample size. So to conclude, considering the simplicity of surgery, early cosmesis and comfort, cost effectiveness, less surgical time and low recurrence rate, our technique of supratenon excision of pterygium with limbal stem cell graft can be adopted for pterygium surgery.
Can you play the video again?
Yeah, sure.
In your video, you have removed a very small part of pterygium mass.
All, I'll be talking on external ophthalmomiasis caused by Ostris ovis, that is a sheep botfly larva. This is done under guidance of Dr. Anshu Sahai and Dr. Muhammad Abid Shamshad. Myiasis is defined as the infestation of living or dead tissue by diphtherious fly diphtheria fly larva and is common throughout the tropics. Most of the cases involve skin, but also can involve eyes, nasal passages, paranasal sinuses, urogenital tract. Ocular involvement is seen in less than 5% of cases. Ophthalmomiasis is commonly seen in farmers, shepherds, and in rural areas. It is most commonly caused by larval form of Ostrus ovis. External ophthalmomiosis involves the bulbar or palpebral conjunctiva, while the maggots penetrate the globe in the internal ophthalmomiasis, rarely to the orbit, causing
Optic membrane grafting in ocular surface burns and in SJS. I have no financial interest in the matter. So we know that the interest in the human placenta is of the amnion, the chorion not being useful to the ophthalmologist, and the amnion has got basement membrane and stroma, which is about 20 to 50 microns in thickness, and the useful feature is that it is anti-inflammatory and it modulates stromal scarring. So amniotic membrane has got a lot of uses on the ocular surface, including reconstruction of the ocular surface in pterygia, but perhaps the most emerging use is in association with limbal cell transplantation, as in SLET. The most important and game-changing use of amniotic membrane, however, is with acute chemical burns of the surface and acute Stevens-Johnson syndrome. So we know that in the grade 4, 5 and 6 of Dua's classification of chemical injuries, amniotic membrane plays an important role. Stevens-Johnson syndrome is a completely different ball game, and the purpose of the video is to show that the surfaces of the skin is denuded and the patient is often on life support system, and doing an amniotic membrane transplantation in the ICU setting is difficult and backbreaking. And in SJS there is denudation of the epithelium, goblet cells and stem cells, both from the palisades of Vogt and the mucocutaneous junction. Gregory's grading shows that severe and extremely severe varieties AM transplantation should be done within 48 hours. The conventional method of doing an amniotic membrane transplantation is to lay the amniotic membrane on the surface, which makes it unsterile, to tuck them inside the fornices and then either put sutures on the lid passing through the fornices or to place a conformer. It is a cumbersome and time consuming and not so sterile process. There are devices like Procera which are available in the United States, and it is basically a polycarbonate ring with a freeze-dried lyophilized amniotic membrane attached to it. The difficulty with this is that it covers only 1 to 2 millimeters beyond the limbus. Some people have used an infant feeding tube coiled on itself to tuck into the fornices to hold the amniotic membrane. So we felt that there was an unmet need, and we wanted a device which could be assembled in the iBank and OT and transported as such, or be assembled locally, and it could be stored like a regular amniotic membrane used under topical anesthesia at the bedside in a matter of minutes. So our design considerations went through open loop devices which we thought would conform to the different sized fornices, and finally we settled into 2 ring devices. The sizing of the device is important, as well as the attachment of the amniotic membrane to the device. So this is showing the dry assembly of the device without the AM. There is a notch in the bottom ring and the top ring is placed on it, and it is snap fits. The assembled device is pliable, so it can conform to fornices of different sizes. So this is how the amniotic membrane is attached. It is placed below the the ring is placed below the amniotic membrane, and the top part is clicked into place. So it can be handled easily like a contact lens and in a sterile manner. So I'll be showing you a couple of usages of the amniotic membrane and how this is a pre-assembled device which was assembled under the microscope. Now it is at the bedside, it is being tucked into the fornix. And this is another case of acute Stevens-Johnson syndrome in a 12-year-old child, in which it is assembled on the gloved hand of the assistant and then inserted into the fornix. The thing that I want to highlight over here is that the amniotic membrane, a skirt of amniotic membrane can be brought out over the eyelid to give coverage to the eyelid, which is important in Stevens-Johnson syndrome. You can then fix it with cyanoacrylate glue to the lid skin. So presenting a few results, this is a young child with a Stevens-Johnson syndrome affecting both eyes, And this is the first post-op day and the 14th post-op day. You can see the red arrow shows the presence of the amniotic membrane, and these are the results at 14 days. This is another case of acute Chuna injury in which there was a conjunctival ischemia which was debrided and amniotic membrane placed with the amserter, and you can see the result. This is another case of alkali burns with a late presentation in which surface debridement was done and the amniotic membrane was used. This is a case of thermal burn, and the purpose of this picture is to show that the extent of coverage of the amniotic membrane that it gives to the ocular surface and the fact that it goes into the fornices prevents formation of symlifera. So the advantages of this device is the elliptical design which conforms to various shapes of sizes of the orbit. It is deformable. It can be used to AM can be used to drape the lids. We have used bilayers, and you can apply glue on the undersurface and put it in. It reduces the surgical time from 1 hour to 5 minutes. It is fully sterile from assembly to insertion, and it can be assembled, and we have stored it at up to -80 degrees centigrade without any degeneration of the membrane or the device. Till now there have been about 8 usages, and many more usages are coming in now, and we are awaiting long-term post-op data. What remains to be done is to educate the critical care specialists and dermatologists to refer these cases early. Thank you.
Thank you, Dr. Rajchaudhary.
Good morning, good afternoon, everybody. My name is Dr. Shikha Mishra, and my topic is conjunctival lymphoma masquerading as conjunctival inflammation. I have nil financial interest. So, conjunctival lymphoma is an ocular surface tumor that usually presents as a painless, mobile, salmon color nodular patch in upper and lower fornices and bulbar conjunctiva. They are primary non-Hodgkin extranodal B-cell lymphoma, out of which maltoma is the most prevalent, followed by follicular and diffuse B-cell lymphoma. They typically have an indolent course with a high 5-year survival rate. About 20% of the patient present with systemic involvement, and especially it is seen with bilateral conjunctival lymphoma. Lymph node palpation and abdominal ultrasound, it primary most to see to rule out the systemic involvement, and complete hemogram is necessary to rule out leukemia, and the treatment generally includes excision biopsy, external beam, radiotherapy, intralesional injection of interferon alpha 2 beta, alpha 2b, and systemic rituximab, brachytherapy, cryotherapy, and observation. So my aim of the study is to diagnose conjunctival lymphoma through clinical features and correlating histopathological examination. It's a prospective case control kind of study where we took 4 cases where 2 were male, 2 were female, and it was conducted between January to May 2019 in a tertiary eye care hospital between 30 to 60 year of age limit. So this is the clinical profile of all my 4 cases, where we see all the cases have a slit lamp finding of nasal and temporal conjunctival mass resembling salmon patch appearance, as we can see in all the cases, all the 4 cases. And case 1 had a feature of left eye having vision 5/60, having NS grade 3 kind of cataract. So we advise the patient left eye phaco with left eye excision biopsy and ultrasound abdomen. Actually all the 4 cases were advised excision biopsy and ultrasound abdomen, but as case 1 had a cataract of NS grade 3, so phaco was advised, and case 2 had a posterior subcapsular cataract due to long-term administration of topical steroids. So that case right eye phaco was advised along with excision and ultrasound. So all these 4 cases, as we see, were typically misdiagnosed as a case of pterygium and pinguicula. So these were on treatment for steroids for around 1 year. So that's why maybe the second case developed posterior subcapsular cataract. So what we have seen in on all 4 cases, the mean age of the patient was 47.3 years, and the cases appeared clinically as pink, red, or yellow subepithelial lesion. So all the cases were advised excision biopsy, and ultrasound evaluation was done along with systemic examination, but we did not see any systemic involvement in any of our patients. Only 2 cases underwent excision biopsy along with phaco and IOL implantation. HP of both the cases revealed subepithelial focal sheets of lymphoid cells with follicle formation and suggestive of atypical lymphoid hyperplasia. So as we see, 2 cases were male and 2 females, and this is a slit lamp picture of case 1 with showing the conjunctival lymphoma picture and the HP of same patient showing atypical cells with large hyperchromatic nuclei scattered among mature lymphocytes and plasma cells. This is the case 2 picture where we see both the eyes showing clinical pictures of the salmon colored patch. But along with that, we see a typical cells with large hyperchromatic nuclei along with mature lymphocyte and plasma cells in the HPE picture. So what we see in our study is we see emphasis of both clinical and histopathological examination. Out of our 4 cases, only 2 underwent excision biopsy with no distant metastasis in any of our cases. Generally, on our 4 cases were observed only with observation, not with any treatment. In irrespective of all the studies where they have given cryo and radiotherapy. As we have seen that our lymphoma cases are mostly localized, so we treated with excision alone, and they were thorough systemic evaluation were done in all the patients. So what is our main thing? We have to differentiate these lymphoma cases from all these differential diagnoses like squamous cell carcinoma, melanoma, papilloma, pyogenic granuloma, episcleritis, scleritis, pterygium, pinguicula, limbal VKC, foreign body, and atopic lacrimal gland. So these all are the differential diagnoses which can easily be misfolded as conjunctival lymphoma, or it can be misdiagnosed as a simple case of pterygium or a pinguicula, but we generally miss it in our day-to-day life practices. So what we see, that any case of bilateral conjunctival focal elevated lesions of long duration having a salmon pink color should be evaluated to rule out potential malignant condition. Patient with disseminated disease can be referred to oncologist team, and a team consists of ophthalmologist, radiotherapist and hematologist are required for better management and thereby minimizing untoward results. So what we should see, some important criteria like what is the histologic subtype of our lymphoma, what is the extent of the lymphoma, what is the patient and disease related prognostic factor, and the effect on the eye and visual function. And so through this proper evaluation, we can prevent to misdiagnose a case of non-Hodgkin lymphoma for a simple chronic or allergic conjunctivitis and other conjunctival inflammation. So my take home message to everyone is, even if it looks like a very benign conjunctival allergic conjunctivitis or a very benign pinguicula or a pterygium, be very careful. It can be turned out to be a conjunctival lymphoma and you can miss a very important diagnosis. So these are my references. Thank you.
Thank you very much. Next we have
Can I have my presentation? 4 to 6 chemical injury burns. The existing medical treatment options are a medical treatment alone, or a amniotic membrane, or a limbal stem cell transplant, which is allogenic presently. So the current standard of treatment is AMG, but a Cochrane database review published in 2012 showed that even if you do an AMG in acute stage, only about 6% of the eyes showed epithelialized surface, both in the mean group, control group and the treatment group. Further, it also showed that even if you put an AMG, the long-term vision was decreased because of the complications of limbal stem cell deficiency. Because of this, the Shankar et al. Group came up with a alloslet wherein they used allogenic, which is a cadaveric limbal stem cell tissue, to put it on the ocular surface and establish the ocular surface. They proclaimed that it was a useful technique to achieve rapid epithelialization, but it would avoid the need of future keratoplasty because it led to decreased melting. But in their study also, 7 out of 18 eyes, there was a gradual failure of the allograft, and 5 out of 18 eyes required a subsequent limbal transplant surgery. So what would an ideal epithelial surface be? Ideally, we would want that there should be a no corneal melt, no infection, no or a minimal corneal opacity, no long-term corneal abnormality, no repeat surgery, a good vision and a stable ocular surface. And all these things are possible by a stable and a sustained earliest ocular surface epithelialization. So how can we achieve that? Is there a new technique which we can adopt? So our aim was again to analyze the outcome of autoslet, that is autogenic slet from the contralateral eye in cases of unilateral ocular chemical injury. It was a retrospective case series performed at our center wherein chemical injury grade 4 or more Duas classification cases were taken, which presented within 1 month of injury. Patients with any prior ocular surface surgery with a retained tuna or children were excluded from the study. Excuse me. We noted the best radial visual acuity, the ocular surface examination on slit lamp, and stress was given to the ocular surface staining by fluorescein. The primary outcome measure was time to epithelialization, because that's what we wanted to have, a rapid and a sustained epithelialization. Secondary outcome measures were BCVA, symboliform formation, and stromal loss. So this is the photographic documentation of the surgical steps. This is how we achieved take the limbal biopsy. Peritomy is done 2 millimeters away for about 1 to 2 clock hours from the other eye, which is the normal eye. The plane of dissection is just deep to tenons. Deep 2 to 3 mm limbal biopsy is harvested. Then this is the origin eye, or the eye which has a acute chemical injury. This is a representative case that was around case 2 from 6 cases I did. So what we do is first we remove all the necrotic tissue around 360 degrees from the on the ocular surface. Tenons is removed carefully, as there is a tenons which hypertrophies again to form the pannus. There is the view after peritomy on the top left. Then what the bulbar surface is covered with the amniotic membrane, which is sutureless, using Baxter's glue, no financial interest. Then the limbal biopsy pieces are cut into around 12 to 14 smaller pieces and distributed all over the ocular surface. And a central complete temporary tarsography is done for about 2 weeks. The arrangement of these cells has been described by our group earlier. Excuse me. The follow-up protocol was standard, and we examined the patient every 3rd day after the tarsography was opened, and then weekly after that. So this is the results. We have done 6 cases till now. These are the images of the prototype case, that is case 5. We see that the preoperatively there was around grade 4 to grade 5 chemical injury with a conjunctival stem cell deficiency from around 4 o'clock to around 8 o'clock, along with the corneal injury. Post-op 3 days, that is after the tarsography is opened, we see that the surface is epithelialized. There is a small defect of around 2 to 3 millimeters, if I can use up here. And then after about 10 days or 24 days, the surface is epithelialized. This is the same patient at 24 days of post-operative course. So this is the table of those 6 eyes which I have done till now. The mean age of epithelialization was 21.5 days. The range was around 17 to 30 days. Within 3 weeks, that is 3 weeks was the time limit set for AMG. So within 3 weeks, 50% of eye, or 3 out of 6 eyes epithelialized, and all epithelialized within a month. The follow-up was up to 211 days at the last visit. The mean vision was 20/69 Snell acuity. The biggest advantage of this technique was that the vision was better because it led to rapid epithelialization. There was no case of stromal melt, again because of rapid epithelialization. And there were 2 patients in which simpliform recurred, but it was only from 1 quadrant. So if we compare my very, very small case series to the exhausted literature, it appears to be better with no donor side complications, no donor side limbal stem cell deficiency, single surgery, no future surgery required thus far, and definitely a better visual outcome. So it's the first study thus far to demonstrate use of autogenic slit in acute injuries. It leads to early epithelialization, no stromal melt, minimal scarring, and it's safe because there is no donor side deficiency. Obviously, a larger study with a longer sample size and a multi-center study would be ideal. Thank you.
It's still very early to.
Accuracy in clinical diagnosis of benign periocular mass lesion, a case series study. Eyelid and the peri-eyelid has skin, which is not only the thinnest, but also among the most commonly exposed to atmosphere and sunlight. In addition to skin, it comprises of appendages, muscle, modified glands, and mucous membrane, so is a site of varieties of mass lesion. And an understanding of the clinical profile and the common characteristics of these, though help in diagnosis, many times may still end up in diagnostic dilemma and may need histopathological confirmation. But when and for which cases do we need HPE, and how often do they match with the clinical diagnosis needs to be evaluated. So we did a prospective interventional case series study with an aim to know the accuracy in clinical diagnosis of periocular benign mass lesions among the patients attending our OPD. We included all benign cutaneous mass lesion in and around the eyelid presenting in both genders at all ages, which may need medical and or surgical care, while excluded the malignant diseases. A total of 279 patients either clinically diagnosed and or histopathologically confirmed benign eyelid masses that were managed between Jan 2014 and December 2016 were included at presentation a detailed demographic data, the symptoms, the time since the mass noted, its location, the size, the physical appearance, any progression or regression or recurrence were noted, and associated systemic ailments were also noted. After this, a pre-treatment clinical diagnosis was made. The required treatment was given, its outcome noted. HPA reports were collected for those cases done. Patients followed up for a minimum of a week post-treatment recovery. The results were then analyzed in terms of the number of cases sent for HPA and their percentage match with the clinical diagnosis. The results showed Total of 279 patients, age range from 6 months to 86 years, average of 35.3 years, female preponderance in 64.5%. We clinically categorize these lesions into congenital infective neoplastic hydrocystadenomas, solar-induced lesions, senile depositive, and those associated with systemic ailments. Here are the few clinical pictures. A congenital subcutaneous mass at the tail end of the eyebrow of dermoid cyst, the capillary, a reddish purple mass which blanch on pressure in a child of less than a year old of capillary hemangioma, epidermal cyst which pose like chalazion, the infected lesion acute internal hardiolum, external hardiolum, the chronic chalazion, dome-shaped pearly white appearance of molluscum contagiosum, sebaceous cyst, the hyperkeratotic nodule within a crater called of keratoacanthoma, exuberant granulation tissue of pyogenic granuloma, the transparent cyst of mole, the translucent cyst of Zeiss when it is away from the lid hydrocystomas, benign neoplastic lesions like nevus and papilloma, the solar-induced mass lesions like the multiple small pigmented dermatosis, papillosa nigra, the stucco appearance of seborrheic keratosis, skin tags, the skin horns, the depositive lesion like xanthomas, those associated with systemic ailments like the nodules of neurofibromatosis, hyperactive sweat glands of syringoma. When we statistically analyze these lesions, the commonest were of the infective type in 64.5%, followed by neoplastic hydrocystomas and solar-induced lesion put together in 26.9%, while rest in 8.6%. Of the infective type, chalazion and hardiolum contributed to 81.7%. We did ask for histopathological evaluation whenever in diagnostic dilemma or in recurrent cases or to rule out early malignancies or of academic interest. Examples like the cyst wall of the dermoid cyst, the nevus typification possible only on HPE, the keratin pearls of keratoacanthoma, the keratin debris of the epidermal cyst, the collection of histiocytes of xanthoma. Here is a table which shows for how many cases and which cases we sent for HPE and how much did they match with the clinical diagnosis. Totally 72 of 279 cases, that is 25.8% cases were sent for HPE, which included 6 recurrent chalazion of 112, 4 did match with the clinical diagnosis while 2 turned out to be epidermal cyst. 6 of 9 molluscum contagiosa were sent, 5 did match while 1 turned out to be syringocystadenomas papilliferum. While 11 out of 20 keratoacanthoma warts were sent, except 1 all matched and that turned out to be seborrheic keratosis, while 23 of 25 hydrocystadenoma, 21 of 25 nevus and papilloma, all cases of foreign body pyogenic granuloma were sent with 100% match. So totally 5.6% did not match with the clinical diagnosis, while 94.4% did match. The common association we found were infective with seborrhea in 81.9%. Owing to unique anatomical features of the eyelid and with all the skin elements, not only numerous but wide varieties of lesion affecting the eyelid are encountered. Aside from aesthetic point of view, the cutaneous periocular mass lesions can either block vision or alter the shape, hence to be dealt. In the present study, most of a lesion occurred in younger individuals similar to other studies but differed in having female predilection while the causes were similar. Though majority of the periocular mass lesions are diagnosed clinically, cases with diagnostic dilemma or of academic interest certainly needs HPE. Hence, we conclude by saying accuracy in clinical diagnosis of lid masses, though good, histopathological confirmation and correlation will certainly enhance the accuracy, and studies on large scale would benefit us and trainees and also essential for better public healthcare planning. Thank you all.
Thank you. So we conclude this session. We thank